Now, the first step is to set up our intestinal drainer by cutting it into two equal halves, as you can see by using a pair of surgical scissors. The cut ends need to be aligned opposite each other. For this, we will use thumb tacks or thumb pins provided in the kit to fix these two cut halves on the foam set of the intestinal holder. Make sure that the cut halves of the intestine are properly secured, or else it might be difficult to carry out with the procedure. As it can be seen, the two front halves of the intestine should align and bulge out. An assistant can help to hold them in place. So here again in our demonstration, we will be doing an end-to-end anastomosis. The assistant will hold these two ends of the bowel loop together. In this demonstration, the mesenteric end is considered facing towards you and the anti-mesenteric end facing towards the assistant. Again, we will be taking stay sutures. Going on to the anti-mesenteric side and taking a fine suture going in from the outside into the bowel lumen and coming out of it just a bit medially on the same loop. Again, the same thing will be done on the mesenteric side, going in from the outside of the bowel and leaving inside out. These stay sutures will help align the two edges of the bowel together. It helps in securing the edges. With the end of the step, we have aligned our two loops together. In this demonstration, we'll be suturing from right to left, which is why we are coming out of the left loop. Now, we will be taking full thickness, continuous, interlocking sutures, making sure that we are taking an adequate chunk of the serosa. Over here, we will be locking every suture. Once it is aligned, we can get the suture out. If you are new to this procedure, make sure you grab individual limbs properly and do this procedure under supervision. Each suture has to be taken approximately 3 to 4 millimeters apart. We can clearly see how the pattern of the sutures is forming along the suture line. The assistant needs to make sure that a traction is maintained on the suture line. As mentioned, we will be locking every single suture. We need to make sure that the bite or chunk of the tissue is adequate and holding your suture. We have almost reached the end. As you can see, this is how a suture pattern should look like. Now we'll be suturing the anterior layer. You can see how the posterior layer is looking. Before we start suturing the anterior layer, we need to again make sure that our edges are properly aligned by taking stay sutures, as we can see. Again, the maneuver will be the same, going outside in and leaving inside out. We can see how the edges have also started to turn on the inside. Now we'll continue with the suturing of the anterior layer. Remember, we will be interlocking every suture. An important thing to remember is to make sure that the edges are inverting properly, because if they are not, the chances of leak will increase. The assistant's help is very much required to maintain traction. Again, as mentioned, we will be interlocking every suture that we take. Also, you can see over here that some edges are getting everted. They need to be inverted so that the edges maintain their form. We will continue to suture the anterior layer throughout the edge, interlocking every suture. Again, the important thing is to make sure that the edges are inverted. Note that while suturing, if you are cutting through the tissue, we can always freshen up a bit of the edges and continue suturing. We'll keep suturing in the same manner where we are interlocking every suture. Again, we need to make sure that our edges are properly inverted. As you can see, we have reached the end. Lastly, we will be tying this back with the free end of the suture. Here, we can see a good anterior layer and a good posterior layer with no gaps in between. Now these sutures will again have to be reinforced by taking Lambert sutures over them. As discussed, this is important to bury the primary suture line and to reinforce it. We will be taking Lambert sutures both anteriorly and posteriorly.
Another Lembert suture to bury this suture line and strengthen it.
These sutures that we are taking are not full thickness, but rather seromuscular sutures which are taken from some distance from the primary suture line. But remember, they should be adequately thick or they will cut through and damage the suture line. So now, when we are approximating, these two ends should come together. The assistant will cut the two ends, and what we get is a primary suture line which is getting buried. We will continue taking these Lambert sutures, which are to be taken at a distance and are intermittent in nature. As we can see, if it is not a proper bite, then we will have sutures cutting through the tissue. So you need to make sure that you're getting adequate chunk of the tissue while suturing. This way, we will bury our entire primary suture line both anteriorly and posteriorly. As mentioned, we will continue taking these sutures even on the posterior layer. Again, make sure to take adequate chunk of the tissue. The assistance help over here is required and it's needed to hold the two loops together and bring the edges together. But be careful that we do not poke the assistant's hand. We can clearly see how the primary suture line is being buried by these Lembert sutures. You can see the entire previous primary suture line varied by the Lembert sutures. At the end of the procedure, we need to make sure we feel the continuity of the lumen. Also, make sure that we have not taken the posterior layer while suturing the anterior layer. Use your thumb and the index finger to palpate and feel that there is nothing coming in between the two fingers. After this, we will close the defect in the masonry. Once the bowel is anastomosed, we need to close the defect in the masonry. This is done to prevent any internal herniation of the bowel through the defect. While doing an anastomosis, we need to make sure that we are achieving proper hemostasis, but at the same time, keeping in mind that we are not compromising the vascularity of the bowel. Because if we are compromising the vascularity, the anastomotic end will necrose and leak. But if you are not maintaining hemostasis, the patient will go on bleeding inside the lumen and will end up with hypotension because of the hemorrhagic shock. Finally, we have completed the anastomosis, which is strong with a proper lumen.